And good afternoon. I'm Dr. R. Dictating, performing surgery on July 25th, 2023 at Deuk Spine Institute here with my team, my very funny team. They make me laugh. We're just cracking up about some stuff. All right, our patient is traveling here from Boston, Massachusetts, and he has a herniated disc in his neck at C6-C7, the second most common disc to be herniated. And it's pinching the left C7 nerve root, which goes down his arm. So we're going to go in there and fix that. All right, just give me a minute. Let me work with my team. The patient is asleep. He's under general endotracheal anesthesia. So 2, 3, 4, 5, 6, 7. Everyone agree? Right approach, C6-7.
Yes, sir.
His neck is perfect. I wish all my patients were like this. Shot. And there it is. 2, 3, 4, 5, 6, 7. Perfect. Let's get an AP view, see where we are. The goal here is to be right over the C6-7 disc in the center, as much in the center as we can be. So that's really good. Okay, lateral. We're just a little bit off to the right side, you can see. But by the time I place the needle, it'll be hitting the center of the disc. Perfect. So I pushed over the trachea and esophagus. Shot. Let's go see, make sure we're centered. Go. I'm right at the front of the disc called the annulus fibrosus. Shot. All right, perfect. Let's go back to a lateral view. Everyone agree we're in the right level?
Yes, sir. Yes, sir.
I'm pushing through the annulus. I could feel it, and we're in. All right, at this point, we're going to advance. So 2, 3, 4, 5, 6, 7. We're sure we're at 6, 7. I'm through the annulus now. Shot. All right, so at this point, we're in the middle of the disc, C6-7. Can you count first, Jordan? 2, 3, 4, 5, 6, 7. So perfect. We're at C6-7. We're going to do what's called a discogram. This is where I inject a little bit of dye into the disc. Let's get, what is that blocking there? Is that the shoulder? A little bit of shoulder. Shot. All right, perfect. Oh man, let's do a little more shoulder because we can see a total herniation there. Beautiful. All right, Jordan, show us the herniation. Look at that, folks. That's the herniation. Huge herniation. Show us the tear in the annulus where the herniation came from. There you go. Very nice. Now, this patient had the option of doing a fusion or an artificial disc, and we discussed both options with him. He had already been offered a fusion, didn't want it. I don't blame him. Who wants fusion? Fusion is where you fuse the two bones together and you put metal in there. It's just totally unnatural. Problem with fusions is they're high risk. They have complications. As a matter of fact, they showed that 50% of patients with cervical ACDF fusion have complications. That was on our board exam recently. All right, so you can see the guide wires at the back of the disc. Shot. Yep. We're ready to go. Knife. I've already given some medicine. We've had no blood loss. We will probably lose 1 or 2 drops of blood. That's all. If you have questions, feel free to ask them. We're going to make a 4 millimeter incision. 4 millimeters, folks, that's pretty tiny. Shot. Now I've got to watch this as we go along. I need to make sure the guide wire does not move back further or come out. Shot. Now what I'm doing is I'm removing the needle, but I'm not removing the guide wire. Shot. So I want to keep the guide wire there and just take the needle out. Now what we're going to do here, shot, I'm going to use the guide wire. So the guide wire went in just a little bit. You see that? Still okay. We're going to use the guide wire to guide this dilator. The dilator's job is to create a passage, to spread things open. Shot. Again, I got to watch that guide wire tip. So the dilator's job is to, remember, under the skin, your body has fibers, kind of like the fibers of a couch, right, or a shirt. Like a cotton shirt. shirts are woven with fibers. And those fibers, if you look really carefully, you can see between them. There's a little bit of space between the fibers. That's what we're doing, is we're going down and we're spreading the fibers apart. As I'm dilating the fibers, it's like putting a pin through a shirt, right? When you put a pin through a shirt, you're not actually damaging the shirt. Shot. I pulled the guide wire back a little bit. Shot. All right, good. I don't want the guide wire going too far. Shot. All right, there we go. See how the guide wire moved forward? So it's being trapped by the dilator tip. Shot. I just got to keep a close eye on it. And I'm actually pulling it back a little bit, so just to be safe. Shot. You can see the dilator tip getting closer and closer to the spine. Okay, it's getting around those tubes. Shot. Now to some of you it may look like the dilator is going through the tube, the endotracheal tube and the esophageal temperature probe, but it's not. Shot. It's actually going past them to the side. I'll show you on an AP view, you can see what I'm talking about. Shot. Perfect. We're now at the front of the spine. I can feel the spine. All right, show them on the lateral view, Henry. Stay on the lateral view. Show them the endotracheal tube that's in the trachea providing oxygenation and ventilation. Show them the esophageal temperature probe. Good, now let's get an AP view. You're going to see that this dilator is not actually going through them, but around them. Okay, that requires some 3D, three-dimensional thought, visualization. All right, there it is. So show them the endotracheal tube. There, good. And the esophageal temperature probe, good. So we're nowhere near those, and we made sure I pushed them over when I went in. Any questions?
No current questions.
All right, at this point, I'm very pleased with where we are. I'm in the center on the AP view. I'm right in front of the disc, and I'm now going to advance my dilator into the disc. I'm going to pull my guide wire back just a little bit. Shot. Okay, good. I'm going to now advance. I'm going to pull the guide wire back because I don't want to advance it too. Shot. And I'm going to twist and push my dilator through the front of the disc, called the annulus fibrosus. Shot. And what it's doing is not cutting the annulus, it's spreading it. Just like putting a pin into your shirt, like a little lapel pin, you know what I mean? I think you guys know what I'm talking about, right? Like a safety pin or something. Dr. Berndes, you're the man. All right, at this point, I don't feel that it's safe to keep pushing, so I'm just going to gently tap it through. Okay? Shot. And there we go. I'm aiming for that tear. You can actually see the tear there in the back of the disc. So I'm going to place the dilator in that tear, and that will give me access to the herniation beyond it. So far, we've lost 1 drop of blood. The whole surgery is done through this tube. It's called endoscopic spine surgery. You might hear other surgeons talking about endoscopic spine surgery, but they don't actually do it. Shot. True endoscopic spine surgery is what we do here at Deuk Spine Institute. I still haven't come up with a good analogy on the difference between what other surgeons call endoscopic spine surgery and what we call endoscopic spine surgery. Huh? I know, I got to figure one out. I can think of one, but it's totally inappropriate. I mean, there's always that one, you know, that guys talk about. All right, fishing. Fishing. There we go. I caught a big fish, right? I caught a big fish. How big was your fish? This big. Oh, that's not a big fish. Then you pull out a 12-foot bull shark, right? That's a big fish. So the point is that some guys think they're doing endoscopic, but they're not. It's actually not really endoscopic at all. I should say guys and gals, but I'm not being sexist. There are some female spine surgeons, more so now than before. As a matter of fact, when I was in med school, 50% of my class was females, which was really good. Medicine needs a female touch. But the problem is surgery is primarily guys, men, you know, and we need more females because males in surgery are just so egotistical. I mean, there are some egotistical females, but for the most part, I'm not trying to be sexist here. It's a little farther than we want. I'm just saying it's still within the herniation. Neurosurgery is dominated by men with just big egos. Shot? All right, so I'm trying to get my tube to the back of the disc, which I feel like we're there. The dilator is sitting in the herniation at this point. All right, I think that's really good. I'm happy with that. Good. We're right at the back of the disc. We're sitting within the annular tear. We're going to go remove this herniation. Any questions?
No current questions.
Okay, very good. So, Henry, you want to show the audience how is it that a herniated disc can cause so much pain? The answer is inflammation. We'll show you how.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. Now you understand that pain in the neck, headaches, and arm symptoms like pain down the arm are all due to inflammation caused by the herniation. This is the herniation, folks, right here. You guys are seeing it. The blue thing that I'm using the laser on and zapping away is the herniation. And what a difference this patient compared to the last one. Look how much softer the herniation is. You don't see a lot of the calcium. You just see the blue stuff zapping away so easily with the laser. Okay? It doesn't take a lot of work, and it's pretty quick. All right? That's the neural foramen over there. That's where the nerve lives, the left C7 nerve root in this case. Okay? Now what I've got to figure out is there's so much blue down here. Which part of the blue is actually the herniation? Which part is the dura, or a little bit of herniation on top of the dura? Remember, the dura is white. Can you guys see that right there? That's like, I think that's dura. I'm going to have to check it out. But we're very close to the dura, the covering of the spinal cord and nerves. This is a young man, a young patient. How old is our patient? 42. 42? 42. So he doesn't have a lot of degenerative disc disease yet. This is an early enough injury that I think we're getting it early enough. It's going to heal nicely when we're done. There's just a lot of herniation down here, Dr. B. Flip. So we're going to take our time and make sure we get it all out. His alternative surgery, there's a piece of herniation. His alternative surgery, by the way, was a fusion or an artificial disc. Now, I don't recommend fusions anymore to people. I certainly don't recommend artificial discs. They're both very invasive treatments. There's herniation right there. You guys see that sitting on top of the spinal cord?
Yes, we do. And we have a question.
Sure.
This comes from Mohammed on YouTube.
Hello, Mohammed. Welcome to our live stream, Mohammed on YouTube.
They said, I have a local spine doctor who recommended to me because I'm 34 years old and I should take an epidural injection to confirm the pain. And the type of endoscopic surgery is using radio frequencies probe. It's called endoscopic L5 to S1 laminectomy ablation of disc herniation and basivertebral nerve. Please ask Dr. Deuk what his opinion is on this type of surgery.
Yeah, I'll give you my opinion. It's a scam. Do not do it. I strongly recommend against it. First of all, laminectomy. That means he's taking bone out of your spine. Okay? And then basivertebral nerve ablation endoscopic is nonsense. Doesn't work. It's not going to work for you either. I would recommend you avoid it. Okay, I recommend you avoid it. Do the real surgery, the Deuk laser disc repair. That is the best. That's why we do this. Of course, I know how to do that surgery as well, but I don't recommend it because it doesn't work. Just so you know, I don't recommend surgeries that don't work. The last thing in the world I want is my patients coming back because what I did didn't work. Okay? I don't have that problem with the Deuk laser disc repair. It always works. Now that may not be the source of pain always 100%. The patient may have some other source of pain. However, the actual disc that we're fixing with the Deuk laser disc repair, always the pain goes away, every time. Okay? So it's not that the Deuk laser disc repair wouldn't work, it's that some people have more than, oh, look at that herniation. Some people have more than one problem. You know, with the lower back, for example, there's 30 different causes of back pain. Now this part of the herniation is older. You guys see how more scarred it is? It's a lot more scarred. See all the golden color? That's calcium. This is old. So earlier we saw some fresher herniation, newer herniation. This is older herniation. All right, so let's see. I need to take care of some of this annular tear. This is torn annulus right here, and it's just kind of sticking in my tube, and I need to get rid of some of it. So I'm going to extend my laser fiber down there, and I'm going to attack it this way. Great question, by the way, Mohammed. I'm sorry to give you bad news. I would not do that procedure. I think it's the wrong thing to do. No, it's taking longer than I thought. Probably another 8 minutes.
We have another question.
Sure.
This comes from Thomas on YouTube.
Hello, Thomas on YouTube.
They asked, what is Dr. Deuk's thoughts on stem cell infusions?
Thomas, great question. My thoughts on stem cell infusions. First of all, I don't believe infusing the stem cells into your veins is beneficial. I would not do it. But I do know that stem cells for joint arthritis pain, like knees and hips, it can be helpful. But we now have a new treatment called Deuk plasma rhizotomy, which is far better than stem cells. All right, for your hips and knees and other joints. There's a herniation, by the way, right there. Let me grab it out. So look into the Deuk plasma rhizotomy for knee pain, shoulder, hip. It's going to replace total joint replacements someday. Completely replace them. unless, you know, you have like an infection or something in the joint, which is not common. But it's going to replace joint replacements for arthritic problems. So I don't believe in whole body stem cell injections. Okay? It's a gimmick. Again, gimmicks are things that are designed to take your money but not provide you with a benefit. And I'm not a believer in gimmicks. I have an opportunity to do gimmicks all the time with my patients. I don't think it's ethical to do that to people, to do a treatment that doesn't work and take people's money and, more importantly, subject them to the risk of a procedure that could be dangerous and cause complications, like injecting your body with stem cells. Okay? Stem cells are basically, they're cells that we're all born with, and they're part of our development embryologically. And of course, some of them persist into the adult life. And what stem cells are is basically a cell that's capable of differentiating into other cell types that are more mature. What that means is, you know, if you look at a fetus, for example, there's no real significant muscle development because they don't quite have muscle cells until later on. But all those cells that were not muscle cells but became muscle cells, well, they used to be stem cells. But as they differentiate, they become muscle cells, or they become bone cells, or they become brain cells. So those undifferentiated cells, they're stem cells, they can become a type of mature cell that you see in an adult. Okay? And if the cell is a stem cell that can become any type of cell, whether it's gut, like intestinal lining cells, or brain, or skin on your outside, or your eyeball, for example. If it's a cell that can become anything in your body, it's called a totipotent stem cell. Totipotent just means that it can become anything. Toti means all. Potent means basically the ability to be all. And totipotent stem cells are found in developing embryos and fetuses. Okay. But I don't believe in injecting them into your veins and into your body. I don't think that's helpful to you. It may make you feel good psychologically, but it's not going to help you medically. And I'm going to tell you one more thing. Because cancer cells are totipotent stem cells, or stem cells basically, you're basically injecting a cancer precursor cell into your body. A lot of people don't know about that. But boy, if they knew, they wouldn't be happy about it. You ever heard of dedifferentiated cancer cells? Look it up. Dedifferentiated. What it means is they're basically moving back towards being a stem cell. So they'll travel throughout your body, and then they'll start growing in other tissues. It's really bad. It's complicated, but as cells get mature, they develop cohesion, adhesion, where they can actually bind to each other and form tissues. Well, a metastatic cancer cell, one that leaves a tumor somewhere, cancer in your body, and travels throughout your body, that cell has dedifferentiated. It's gone from being a mature cell that binds to cells around it and stays where it belongs, to being a cell that invades your blood vessels and becomes non-bound. So it's going the opposite direction of what you want. It's becoming less predictable in its nature. Huh? More oncogenic, yeah. Cancerous. The more germ cell-like cancer cells are, the more aggressive the tumors. the more aggressive the cancer. So basically, when you're injecting stem cells in your body, you're potentially injecting something that can become cancer throughout your body. I think it's a really bad idea. And a lot of doctors are so greedy, they don't care. They'll just take your money, and you think you're doing something good for yourself, but you're not. All right. I need to go the other way. So this is, I thought it would be a quick case, but there's a lot of herniation. And I'm just getting to where I can start see things a little better. So let's get a little deeper and see what we got here. I still think there's herniation here. I see it. So I'm going to have to pull my laser fiber back a little bit. And I'm going to have to go after that stuff right there. Any questions?
Yes, we have a couple. This next one comes from Bobby on YouTube.
Hello, buddy.
And they asked L5 to S1 par fracture spondylolisthesis, grade 2.5.
Oh, my God. Yeah, that's bad. If it's a grade 2.5, almost 3, that kind of case is one I would recommend you consider fusion, if that's the case. Because I think laser surgery is fine for a grade 1 or a grade 2. But once you start getting to a grade, look at this herniation, it's just sitting on top of the spinal cord. Once you get to a grade 2.5, 3, that's, yeah, thanks. That's pretty bad. That's pretty bad. I would say I could probably do it with laser, but maybe 50-50. 50-50 that you need a fusion. Look at this giant herniation right here. I'm about to unlock it. It wants to come out. You can see it jiggling around right there. You see it? I'm blasting at it. There it is. It's coming out. Now, this is an example of a, most cervical herniations are called subligamentous. They're below the ligamentum flavum. This one is through the ligamentum flavum, completely through. Look at that. This is the ligamentum flavum, here, the posterior ligament, posterior ligament, and it blew right through it. Look at that herniation right there. It's still sitting there on top of the cord. Amazing. That's the last of it right there. So I need about 5 more minutes, Doc.
You got it.
Yeah. This is taking me a little bit longer because it's so delicate. His herniation is so big. Yeah, thanks. You can see how the spinal cord right here has been pushed in, and there's basically the herniation. A lot of scar tissue right here.
See that sloping effect there.
I'm sorry?
It's like it's sloping down.
It is sloping down. You're right. That's exactly what's happening. It's sloping down because the herniation is digging in right here to the spinal cord. And I'm literally 0.5 millimeter. Look at that. Here it comes. Right off the spinal cord. Boom! Still a little bit of scar tissue. It's all just hiding back there. And we are releasing it. It's all scar tissue, PLL. Oh my gosh, that's beautiful. Look at it. Amazing. I just love this surgery. Here it is. And it's all calcified too. Look, it's been an old herniation. Been there for a while. You cannot do this surgery without the laser, folks. Impossible. Right, Luis? Remember, that fiber is, oh, there it is. There's another piece right there. Oh, it's beautiful. Folks, gone are the days. Oh, look at the herniation come out. No more ACDFs. No more artificial discs. It's over. This is the birth of a cell phone right here. Electronic vehicles. However you want to look at it. This is the advance of technology. 2 million spinal fusions a year in the United States. It's all going to be gone. You know? It's just a matter of time. And we're the first to do it. And to bring this technology. Very delicate surgery. Literally sitting on top of the spinal cord here. And I have to be very careful. We haven't gotten it all. Remember what I taught you before, we can't get all of it. It's just not possible to get it all. Okay? So don't expect 100%. If you go for 100%, you'll have complications. Wow, that's a lot of herniation there. All this is scar tissue. Literally, it's shoved back the spinal cord and the nerves. So far back. Okay? Anyway, I'm enjoying it, but if you have questions, feel free to ask.
Yeah, we have a couple questions. This next one comes from Smedley on YouTube.
Schmedley.
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 And they asked,
Schmetten.
they asked, Dr. Deuk, do you arthroscopically remove bone spurs as well as herniations?
Yes, we're doing it right now. We're removing bone spurs, my friend. You don't see the bone spurs we removed? They are there. The bone spur was up here, for example, right there, gone. All right, so we do take bone spurs out. I don't take every single bone spur out because there's no point. There's just a little bit of herniation left. And I want to make sure we've gotten enough of it. I think there's more here. I'm going to take a look. Okay, I got to peel back this PLL. Yeah. What other questions do we have?
Next one comes from Mohammed. I think it's just more of a concern or advice, but they said, thank you for answering my question. Very much appreciated. And
Welcome.
And that doctor was the only one in 100 miles distance. I am more convinced in the Deuk laser disc repair. The only concern is the hole left after the surgery.
the hole left after the surgery. You're funny. What do you think the hole is going to be like when he does a laminectomy on you? There's a massive hole. This hole right here, look at the herniation sitting in there. Look at this. This is it. This is it. This is the dragon. Look at the size of this thing. It's huge. Here it comes. Here it comes. Oh my God. Or Allah, whatever you prefer, but look at the size of this thing. It's sitting on the nerve and the spinal cord. It is about to come out. It's shaking. It knows its days are numbered. There goes a piece of it. No, this hole that we have here, my friend, I want you to think about this. You see the tube, the inside of the tube? This is the cervical. It's different than lumbar. But the hole we're leaving is 2.5 millimeters. Your body can heal a 2.5 millimeter hole. No problem. The laminectomy hole that your doctor is going to do on your spine is more like 2 centimeters. That's 20 millimeters. Much bigger. And it'll never heal, by the way. Never. Never heal. Never. Okay? So why would you want to make a giant hole with laminectomy? It makes no sense. Knowledge is power. A lot of doctors don't know any better, but you, the patient, should. If your doctor doesn't want to learn, you have to learn. All right, look at that. Pretty much, that's almost done. I'm going to check the foramen, and we're going to be done. Oh, yeah.
We have, oh, sorry.
Yeah. I was going to say, I think we've gotten about, I would have, if I had to guess, 70% of the herniation. I'm almost done. Probably another 3 minutes, doctor. But I will take your questions, yes.
This next question comes from Bobby, once more on YouTube. And they asked, how do you do a 360?
A 360.
I assume that's with the endoscope.
That's okay. Yeah, there is no such thing as a 360. Okay, a 360 is a fusion procedure. All right, it's where you fuse in the front, the back, of the spine, and then you go back again.
That's an anesthesiologist's nightmare.
So it's a highly invasive surgery. I stopped doing 360s 20 years ago. It's totally unnecessary to do a 360. If that's what you're asking me about, is a 360 fusion. 360 fusions are way invasive, far more fusion than you need. And the only reason to do a 360 fusion on a patient is if you have to make some payments on your Mercedes and you need the payment, you need the money quickly. You do a more extensive fusion like a 360. Then you get lots of money and you pay off your bills. Oh, sorry, did I say that out loud? I mean, that's really the only reason. Yeah, they'll approve a 360, the insurance companies, because they're, well, a lot of them have reduced their risk because they pay one fee for a fusion. Like Medicare doesn't care, you know, how you do it. If it's extensive or not, they're going to pay you one fee. We don't do 360s anymore here at Deuk Spine. We do real surgery, good surgery, surgery that helps people. Less invasive, faster recovery. All right, well, I've gotten all I can. All that's left here is scar tissue, and the spinal cord is going to take time to come back. I can't make it come back. Nobody can. But you can see it's gotten pushed in there. I just want to make sure I'm not leaving anything behind. And right now, it looks pretty good to me. I can see the blood vessels down there. See those little blood vessels in the foramen? There's a little piece of herniation there. I'm going to try to get it. But again, this is where you gild the lily. This is where you can have problems, and you just don't need to do that, you know. I've opened up the foramen nicely. Everything is looking loose and jiggly, and you can see the bleeding is a sign of decompression. Oh yeah, look at that little piece right there. I think we're done. Yeah. That's really good. I'm very happy with that. Did a really good decompression. Why don't you type up your questions? I'll come answer them. But this was a single level C6-C7. Patient is from Massachusetts. Came to Florida for the Deuk laser disc repair. This is the only place in the United States you can get the Deuk laser disc repair currently.
More expecting in here.
We will have more centers opening up because it's such a highly successful procedure. We're going to be opening centers all around the United States and then eventually the world. But right now we have just one location in Melbourne, Florida, near NASA, where the space shuttle is, and SpaceX, Blue Origin, all the United Launch Alliance. This is where Deuk Spine started. But it is not where Deuk Spine shall end. All right, great questions. Let me show you how small the incision is. You have a tape measure? So the whole surgery, folks, was done with a 4mm incision. Henry, you see this?
Yes, we do.
You guys see it?
Yes, we do.
No surgeon in the world can do that except a
4mm 360.
4mm 360. Only probably less than 5 in the world can do this kind of surgery. And I'm the only one in the United States. Don't ask me who the other 4 are, because I don't know that there are any others. But it just sounds like a good number. Let me just say, originally this was pioneered in Korea, South Korea. And since then, the surgeons that were doing it, they don't do it anymore. They had some complications. All right, DLDR. This was a right approach. C6-C7. Everyone agrees? All right, Henry, you want to take our audience away for a nice, let's share one of our patients' stories with them, and then I'll come answer questions.
Good morning, I'm Dr. Ara Deuk-Majan, CEO and founder of the Deuk Spine Institute, here with one of my patients who traveled from Mississippi.
Yes, sir. Oxford, Mississippi.
Oxford, Mississippi, which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Deuk Spine Institute here in Florida?
I'm having issues with my lower back, shooting a pain all the way down towards my elbow, as well as having a little bit of stumbling while I'm walking within my left leg, and went to other physicians to look at my spine, whatever, and they wanted to do fusion and all kinds of other nonsense that I thought maybe there might be a simpler way, a process of doing things. Did a lot of research and found Dr. Deuk here.
And what do we do for you?
You guys did a C3, I think 3, 4, 4, 5, 5, 6, at the Deuk laser disc repair surgery.
And before surgery, you had neck pain?
Correct.
For how long?
It's been ongoing probably for about 5 years.
And then pain going from your neck into your right shoulder, down your right arm?
Correct, just getting progressively worse. And that's kind of what made me finally to say I got to definitely do something about it.
Here we are less than 24 hours after your surgery, the Deuk laser disc repair. You can see the incision right here, it's 4 millimeters. And do you still have that neck pain and pain in your arm?
No, sir, zero pain.
Gone?
Gone, completely gone.
Cured?
In shock. Results better than I actually anticipated, which is a good thing, right? That's what I'm here for.
Well, I'm not shocked. It's what we expect to see typically, which is good. The procedure works, and that's why we do it. It works better than anything else. Were you offered any other treatments?
Yeah, they wanted me to go look at a, what do they call a spinal deformity doctor. And they possibly looked at like doing rods and pins and all that kind of good, the fusion and everything. So it just kind of...
Why didn't you want to do the fusion option?
Long time recovery time and just more of a difficult surgery.
Yeah.
Much more difficult surgery. And me working in a house, I still want to have good quality of life in the future.
Yeah. Well, fusions have complications, a lot of complications. Scar tissue, bleeding and pain. Are you having any pain right now from the surgery?
No, not at all. Just a little stiffness when I turn left to right, but that's par for the course.
Yeah, the stiffness is going to take some time to work out.
Sure.
You've had bad arthritis in your neck, your discs were degenerated. You had degenerative disc disease and herniations and bone spur at C3-4, C4-5, C5-6. We went in and fixed all three. You will need therapy to increase the range of motion. It'll take time and you'll get better. Are you happy with your decision to come to Deuk Spine Institute?
Very happy. I flew all the way down here from Oxford.
Yeah, very good.
So absolutely made the long trip. I fly back Saturday. And I feel much better flying on the plane than I did earlier. Just thinking, I'm not on any kind of pain medication, none of the muscle relaxant. There's zero pain, so I feel more comfortable hopping on that plane.
And we did it all through a 4 millimeter incision. You could actually see the incision with the little tube going in to your discs. I moved the tube from one disc to the next, and we went back to the back of the disc where the tear was, and I cleaned the tears up with the laser. So that usually does the trick of getting rid of the neck pain when it comes from a herniated disc. And of course, we unpinched the nerve roots that were going down your arm. So that's why your arm is feeling better as well. I don't expect any of that to come back. You should be pain-free the rest of your life. Just don't re-injure the discs.
Absolutely. I'm definitely glad to get my quality of life back. That's the number one thing.
Anything you want to tell your audience?
Anybody that's dealing with the same issues I have, I definitely recommend to come to the Deuk Institute of laser surgery. It's a wonderful thing.
All right. Well, congratulations.
Thank you so much. I appreciate it. Thank you so much. We will.
Yeah.
Well, my dad lives in Tampa, so my wife's up there in Oxford taking care of her stuff up there. So worked out good to have my dad here to pick me up and drop me off at the airport tomorrow.
All right. Sounds good. Well, safe travels for you then.
Thank you so much. I sure appreciate it.
My pleasure.
All right, that was a great testimonial to hear, and one of our patients share their experience. So this person that I just did surgery on, and you've been watching with me, They had a herniated disc at C6-7. And the way we figure that out is we know that the spine has 7 bones in the neck. So you've got the number C1 at the top, 2, 3, 4, 5, 6, 7. And this person's herniation that we just finished was C6-7. Now the herniation was in the back of the disc and it was hitting on the spinal cord and nerves. Matter of fact, it was digging into the spinal cord, and you can see in this video how I was peeling it, the herniation, off the spinal cord and nerves, literally a 1/10 of a millimeter at a time. That's the accuracy and precision of a laser, a 1/10 of a millimeter. I can literally hold the laser just above the area I'm working, and I sweep it right over up in the air, not the air but in the water, and it basically peels almost a cell layer at a time. That's how precise the laser is. There is no tool more precise. And the reason I can do that, number one, the laser's capable of doing it, but number two, I can see what I'm doing at a 1/10 of a millimeter. What other surgery in the spine gives you a 1/10 of a millimeter visibility? None. All these spine surgeons talking about how open spine surgery is better, lasers, forget about it. That's because they don't do laser spine surgery, but if they did, they would never go back to open surgery. Well, as long as you paid them millions of dollars, they wouldn't go back to it. But as long as they're making millions of dollars doing fusions and artificial discs, they're going to keep recommending them to you. And by the way, they won't recommend a fusion right away. They'll recommend a laminectomy first. They know if you get that laminectomy done, they're going to be peeling off bone and ligament off your spine permanently. And that's going to make your spine wobbly, which they know it's just a matter of maybe a year or two before you're back begging for a fusion. So they're setting you up. They're kind of like that high school drug dealer that gives you a little whiff of cocaine or methamphetamine at the party for the first time. And then you get hooked on it. And then you got to have more. And then they know you're going to be coming back like a kid to a candy shop. That's what these spine surgeons are doing to you people out there. Getting your laminectomies, your discectomies, your microdiscectomies, your interspinous device, your barricade device, your disc seal, your mild procedures, your spinal cord stimulators, your epidurals, your facet blocks, your RFAs. The list goes on. I could just like a tick-tock, keep going. The truth is, they are milking you for your dollars and the insurance company money. And the only way you people are ever going to get out of this spiral down the drain is to know the truth. You got to first know you're spiraling down the drain. Then maybe you can do something about it. So it's not my job to save the world, but it's my job, I feel it's my job to educate people, to know what the truth is, and to teach you all about it. What you do with the truth is up to you. I can't force you to act on it. And if you don't want to act on it, well, you're fine. That's fine. You know, kind of like the Matrix, right? If you want to be a human battery and you're happy being a human battery, then be a human battery. On the other hand, if you want freedom, you want truth, you want knowledge, I'll give it to you. But what you do with it is up to you. All right, first question.
First question comes from AP. AP
on YouTube. Welcome to our live stream.
They asked, I have extreme numbness but no pain from my navel to my toes.
Ooh.
Are these signs of a herniation?
Yeah, AP, numbness from your navel to your toe, that is bad. That means you have a T10 sensory level. That means you have a spinal cord injury. You have something very serious going wrong. You must seek medical attention immediately. If you have not gone anywhere, go to the emergency room now. Don't even finish this broadcast. Literally, go to the emergency room. Numbness from your belly down means your spinal cord is getting crushed. You're becoming a spinal cord injury patient. I just had a patient like this from Seattle. He was 14 years old, and they missed his diagnosis of spinal cord injury. He came here and had the laser surgery 2 weeks ago. Okay? But he is, you know, numbness from your belly button is where your T10 spinal cord is and nerves are. So if you're numb from your belly button down, that means you have what's called conus medullaris syndrome. Conus medullaris syndrome, spinal cord injury. So please go get it checked out. If it happened gradually, it's probably a herniated disc or a tumor, if it happens suddenly, it could be an infarct of your artery of Adam Kiewicz, which is a special artery that runs right around T10 and supplies the spinal cord. But whatever it is, it's serious. So go get it taken care of now, the emergency room, immediately.
Next question comes from Smedley on YouTube. Once more, and then they said this is a two-part question. The first one: do you ever enter posteriorly via the foramen keyhole if more bone spurs are in the back? And two, would you like uploads of my thin slice CT as well as the MRI? I've been told CT shows bone spurs more.
Smedley. Yeah, so first of all, I do not go posterior. Of course, let me back up. Smedley is asking me, when you have a herniated disc in the foramen, in that hole there, right in the front of your nerve, do you ever go through the back and drill a hole back here and unpinch the nerve through the back? The answer is I've done that thousands of times, thousands of foramenotomies, thousands. Probably, if I had to say, at least 20,000 foramenotomies in my career, okay? Most of them were done during a posterior cervical laminectomy with foramenotomy infusion. That's where I go in the back, make a cut, peel the muscles off the spine, and then drill the entire spine out, pull it off, exposing the spinal cord and the nerves from the back, and then I open the foramen with a Kerrison rongeur. Done so many, 500 of them in my career, and each one of them is, 5 times 2 is 10. So thousands of foramenotomies, probably actually around 10,000. Cervical, but not even including lumbar. Lumbar is another 10,000. Point is, I don't do it anymore because it's unnecessary. The surgery you just watched right now obviates, if you understand what that means, the need for posterior decompression of the foramen, because I'm decompressing the foramen through the front. Decompressing the foramen through the front is the best way to decompress the foramen. The problem is 99% of spine surgeons don't know how to do it. So all they know is the old-fashioned way of doing it, which is to go through the back and drill holes. Terrible idea, because it's going to weaken the spine. You're going to have to do fusion. I wouldn't recommend that. The other question was, do I want your thin slice CT? Absolutely. When you upload your MRI or send us your MRI, send us your CAT scan as well.
Next one comes from Mohammed, once more on YouTube, and they asked, well, Dr. Deuk, you are the best in your crew as well. Looking forward to meeting you someday. Do you do neck and back disc repair at the same time?
Hello, Mohammed. Thank you for your kind sentiments and remarks. I appreciate it, and I'll share with my crew. We do lower back on a different day than neck, because the lower back surgeries are through the back, where the patient is laying on their belly, whereas the neck surgeries are done usually through the front. So typically we would do one on Tuesday, the other one on Thursday, or one on Thursday, the other one on Tuesday. So we would break it up, but you could do it in the same visit.
And that is it for questions.
Okay, wonderful. Thanks so much for asking. We have one more surgery left today on the 25th of July. The next patient is a lady who has herniated discs with degenerative disc disease in her lower back. She has L3-4 bilateral degenerative disc with herniation, causing back pain and pinching the nerves going down her legs. I'm going to go in on both sides and do the endoscopic surgery, open up the holes where the nerves are, treat her back pain. I'm also going to go to the L4-5. So I'm doing L3-4 bilateral and L4-5, I think, on her left side,
yeah,
maybe?
Or
Right side.
Yeah.
All right.
L3-4 bilateral L4.
Don't worry, we'll get it right.
No
We have it
worries.
all written down.
All good.
So that will be next. That will be our last surgery.